Good evening. My name is Scott Springer. I am a physician assistant located in Buffalo, New York. I work at Erie County Medical Center, which is a county hospital here in Buffalo. My specific practice setting is an outpatient hepatology clinic. So I'm not affiliated with the transplant program, but we manage a lot of patients pre and post-transplant, bridging them to a transplant. So we see a wide range of chronic liver disease. Additionally, I also manage patients with substance use disorder, with and without overlapping chronic liver disease. So that's why today's topic of alcohol and metabolic dysfunction associated steatotic liver disease and navigating that relationship is of interest to me, and I'm excited to talk about. So we're going to kind of go over a handful of questions about this relationship between patients with MASLD or MASH and their alcohol use. So one of the most important things, because MASLD and MASH are diagnoses of exclusion, and the diagnosis can change from MASLD or MASH to MET-ALD to alcohol-associated liver disease or ALD based off a patient's quantity of alcohol use. Assessing accurately how much alcohol a patient is drinking is really important to what we're doing here. So how do we do that? How do you effectively screen for alcohol use? How do you quantify alcohol consumption? First off, I think the most important thing that kind of is primary to everything in managing patients with potentially behavioral associated liver disease, developing a really good patient-centered, non-judgmental relationship with the patient and how you're taking your history plays a big role in that, even from the first meeting. Okay. This is something that you develop over time. But that, like I said, that first meeting is really important because talking about behavioral issues, substance use disorders, things that patients may be uncomfortable about or be stigmatized and they have shame about, how you approach it's really going to change the outcome and how accurate of information you're getting. Okay. So that's kind of the baseline. What I would say as far as quantifying alcohol use, the best way of doing it is not try and get the patient to tell you in standard drinks how much they drink. A standard drink is about 14 grams of ethanol, which is, like a 12-ounce beer, or a 4 or 5 ounce glass of wine, or a shot of liquor. So patients are not good at quantifying standardized drinks, and that's okay. So if you're asking a patient about their alcohol use, usually what I would recommend is instead of saying how many drinks do you drink a day, I would say something like, what is your, tell me about your alcohol use. A good question to ask is, what do you drink? Like specifically, like not just I drink wine. Okay. Wine varies in alcohol content. Wine bottle sizes vary. Same thing with liquor and beer. So I specifically try to ask what the patient drinks and how much they go through, say in a week or in a day. So that can get you a really accurate quantification. The reason that accurate quantification is important is because we want to be able to assess change over time. Is the patient's alcohol consumption worsening? Is it improving because of interventions that we've used? So that's why it's really important. As far as screening, like evidence-based screening tools, I don't really use these because I have kind of my own approach to broaching this topic with patients. But evidence-based, there's an evidence-based for something called SBIRT, which is an acronym that stands for screening, brief intervention, and referral to treatment. So a brief intervention is just like a short interaction in the context of a medical appointment, where you discuss alcohol use, you kind of can bring it up. And if you're screening using something like a one-question screening, like a validated one-question screening, like how many times in the past year have you had 4 drinks in one day if it's a woman, or 5 drinks in a day if it's a man, that can prompt you to say, oh, they said, at least once. That's a positive screen. You could proceed to something like an audit C screening, which can help you hone in on patients' alcohol use disorder. In my opinion, just assessing for problem drinking is more important than getting a diagnosis of an alcohol use disorder, on that first visit or over time. But those are some of the evidence-based tools for it. Another really important tool that I've been using more frequently in my practice is PEth testing. PEth is it's a shorthand for phosphatidyl ethanol. It's essentially a direct biomarker of alcohol use, recent alcohol use. The way I kind of explain it to patients who have an understanding of what a hemoglobin A1C is, or other clinicians, is it's kind of like a hemoglobin A1C for alcohol consumption. So if the PEth is elevated or positive, we know the patient's been drinking recently. There's a couple other direct biomarkers that are recommended for use, including urine ethyl sulfate and urine or hair ethyl glucuronide. These are good because they're cheaper and they're also direct biomarkers. Those three, the PEth, the ethyl sulfate, and the ethyl glucuronide, are all recommended for use in patients with potentially liver disease, because liver impairment doesn't impact those tests. So that's why they're good to use. And why do I use testing in patients? It's not to be like, oh, are you lying to me? I'm going to catch you. No, it's not about that. It's about kind of having some accountability with the patient. So it's a matter of, you're going to tell a patient that you're using this testing on them. Because if you do it and you're like, I got you, I didn't tell you I was doing this, but I suspected you of drinking, even though you didn't tell me, that's just going to completely sabotage the therapeutic relationship. And you're not going to actually be able to do anything meaningfully from a behavioral intervention context with these patients. So we use these. They're helpful in kind of identifying and differentiating between true MASLD, ALD, and ALD in patients. But again, it's not to catch the patients. Next, I want to talk a little bit about the detrimental effects of concurrent alcohol use in patients with metabolic dysfunction, and specifically how that pertains to their liver disease progression. So we do know that alcohol use, independent of cardiometabolic risk factors, leads to hepatic steatosis. So even if you have no cardiometabolic risk, drinking alcohol in quantity frequently will put fat in your liver. Okay. When you have fat in your liver and when you're drinking alcohol and the toxic metabolites are accumulating and injuring your hepatocytes, there's a variable extent of fibrosis development. So in addition to fibrosis development, we know patients with chronic liver disease, if they're drinking alcohol, they have worse outcomes. Okay. So independent of metabolic risk, we know that heavy alcohol use is associated with progression to fibrosis and worse outcomes for patients with chronic liver disease. Okay. What are some of the recommendations around this? So the ACG and their alcohol-associated liver disease guidelines, they recommend avoidance of alcohol in all obese patients and all patients with type 2 diabetes, without even history of MASLD or identification of hepatic steatosis. So it's pretty strongly worded that patients with metabolic dysfunction should not be drinking alcohol. Okay. Similarly, the AASLD guidelines recommend that patients with chronic liver disease should be counseled that there is not a safe amount of alcohol for them to drink. So abstinence is best for any patient with chronic liver disease. So whether it's metabolic dysfunction associated steatohepatitis or some other liver disease, the major societies in their guidelines say these patients should not be drinking. Okay. Delving a little bit more into it, I think one published piece of evidence that suggests the horrible relationship between alcohol use and progression of steatotic liver disease, steatohepatitis, was a retrospective cohort study published in Gastroenterology in 2024. What it did was it utilized VA data, identified more than 1 million veterans with steatotic liver disease, and it assessed the outcomes in these patients relative to the reported alcohol use. Okay. Essentially what it showed, or the data suggested, is that individuals with high-risk alcohol use had a 43% higher incidence of cirrhosis. So these are patients with steatotic liver disease and risky alcohol use. They had a 43% higher incidence of cirrhosis relative to the people who had no alcohol use. And this was consistently seen across subgroups, including gender, race, ethnicity. So, at least based off of this data, very large cohort, it does seem like heavy alcohol use leads to advanced chronic liver disease. On the flip side, another takeaway from this is that it was noted that in patients who had high risk use at baseline, those who decreased their alcohol intake over the course of follow-up had a 39% lower risk of cirrhosis relative to patients who did not change their alcohol use. So essentially, what does this mean? It's never too late. So yeah, we know it's bad to drink. We know it's going to most likely lead to more rapid progression to fibrosis and cirrhosis, decompensation, potentially HCC. But like I said, it's never too late. Stopping alcohol use is always beneficial to the patient, okay? Unless they're going to go into acute withdrawal. Even with addressing, the limitations to this type of study, retrospective cohort studies, and the study design, this is still extremely impactful data that kind of sheds some light on this relationship for us, okay? Just a couple more things to talk about here. Really important. What are some of the practical management strategies for a patient diagnosed with MASH? who also consumes alcohol above recommended thresholds. So the big picture for this type of patient is that multidisciplinary care is the key. Ideally, you want comprehensive metabolic care, as well as comprehensive substance use care. Okay. If you're able to integrate behavioral health, metabolic medicine, addiction medicine into your GI or hepatology practice, that is ideal. Very few places do this, but this is kind of going to be the new model and gold standard of how we manage these patients. Okay. The reason that integrating this type of care in your practice is so important is because there is abundant data that referring patients to specialty care for things like substance use disorders, these patients fall through the cracks. They do not actually arrive at the place of care. And if they do arrive there, they don't do very, they don't stay engaged in treatment or have good outcomes associated with it. So integrating care is really valuable for these patients and it serves them best. I would say if referral is your only option, which for many of us it is, it's really important to form strong relationships with community programs that manage things like metabolic disease or substance use disorders. And specifically when it comes to substance use disorders like alcohol use disorder, you want a place that has like a low threshold for patient access. So not a place that's going to make it really hard for the patient to get there, limited hours, low accessibility. They don't have telehealth visits, things like that. No, you want to make it as easy as possible for the patients to link with this. Okay. And ideally, if you're getting them to a behavioral health expert, someone that or a program that has integrated psych care is really, really valuable because in patients with co-occurring substance use disorder and psychiatric conditions, integrated care is very valuable. Okay. The last thing I'll say on this is if you are not a behavioral or metabolic expert, now is the time to start learning it. From my experience, yes, of course, you want to have a full understanding of all the facets of this, but really what it looks like a lot of the time is just utilizing patient-centered care, learning about interventions like motivational interviewing. Even if you're not formally using motivational interviewing, incorporating the spirit of motivational interviewing into your encounters with patients, addressing ambivalence, promoting change-oriented behaviors, and always maintaining a collaborative approach with your patients and using shared decision-making. If you're not prescribing medications for alcohol use disorder, things like acamprosate or naltrexone, I would recommend start doing so because your patients could certainly benefit from it. Okay. And then in the most extreme of cases, talking about things like motivational interviewing, ambivalence, some people don't want to stop drinking. And if it's something that you push with them or push them towards, and it's not something that they want, that really sabotages that relationship, and you can actually wind up doing more harm than good. So there's a value to understanding concepts like harm reduction, contingency management for patients that aren't yet in a stage where they're looking to change, or maybe they never will be. Okay. Just because someone doesn't want to stop drinking alcohol completely doesn't mean that you can't still help them optimize their progress and outcome. So, you have to listen to what the patient's telling you and kind of get on their level with where they're at with things, and not push things on them that they're not ready for. Okay. Finally, we'll wrap it up here. How does ongoing alcohol consumption impact the interpretation of liver function tests and non-invasive tests? And how does it impact the patient's eligibility for potential mass pharmacotherapies? So certainly we understand that multiple co-occurring liver diseases will complicate our understanding of what is causing the liver injury. Okay. When it comes to non-invasive testing, something like a FIB-4, things like aminotransferases and platelet count can be impacted by alcohol use. So that could potentially artificially inflate, a FIB-4 score. We know that elastography can be less accurate in people who have acute hepatitis, and there's lots of inflammation going on. So if someone is drinking alcohol and there's like an acute alcohol-associated hepatitis, that certainly can skew those results. And ultimately, we can't differentiate between steatosis or fibrosis, the etiology of the steatosis or fibrosis based off of elastography. So, there's no distinct features, like there are on a biopsy. So it's hard to differentiate, and it doesn't always tell us much. Okay. It is important to note, however, that when patients have steatosis from heavy alcohol use, we know that steatosis can rapidly resolve with alcohol abstinence. We're talking a matter of weeks potentially. So knowing this can be helpful when we're following patients with co-occurring alcohol use and MASLD or MASH, because we know if the patient truly is doing a good job reducing their alcohol use or abstaining from alcohol, if there's still steatosis, despite that, we know that most likely the driver of that's the metabolic dysfunction, which can help us kind of reallocate what we're focusing on with them. Okay. Lastly, I will say by definition, talking about how does this impact their access to pharmacotherapy, by definition, patients with heavy alcohol use and hepatic steatosis, they have met-ALD or ALD, not MASLD or MASH. So Resmetirom, the only medication that we have at this point indicated for MASH, is indicated for MASH. It's not indicated for ALD or met-ALD. So, that is an issue. There's unclear safety of these medications, Resmetirom with concurrent alcohol use. I think there's data upcoming on that, but we don't have that data yet. So it's unclear. Is it safe for these patients to use this medication? And again, the medication might not even be approved and accessible for the patient if they're drinking more than the published thresholds that would keep them under the threshold for met-ALD or ALD, okay? So those are big concerns. One thing that I will say is somewhat promising is that GLP-1 medications, there is some evidence anecdotally, and it's currently being studied, that use of these medications, we know that there is evidence that they can be helpful for regression and fibrosis in MASH, but also that they may have utility in substance use disorders and reducing risky behaviors like heavy alcohol use. So one thing I will say is promising is that I hope in the future we do get GLP-1 medications approved for use in MASH, and they may actually have nice utility for us in patients with co-occurring alcohol use disorder and helping reduce alcohol use. So yeah, that is my thoughts on the topic. I appreciate you sticking around to hear me. If you have any questions, please don't hesitate to reach out, and have a good night.